Good morning. My name is student Dr. Madisen Janssen, and today I'm going to be talking to you about a woman named Maria in Major Depressive Disorder. Who is Maria? Maria is a 38-year-old female who is a sociology professor up for tenure in 3 months, and she swims 1 mile 3 times a week. What is bringing Maria to the doctor? Maria came to the doctor complaining of a persistent headache that is causing low-grade pain and has episodes of exacerbation. She has also mentioned that she has not been able to get more than 4 hours of sleep in a night in over 1 month, and that she has diffuse tenderness above her elbows and ankles. In addition, Maria has a family history of suicide and autoimmune conditions. Her great uncle and cousin committed suicide in their 30s, and there is maternal history of ulcerative colitis and IBD. Objectively, Maria has a BMI of 21.6 and a blood pressure of 141/91. This is what we know about Maria. Now, onto what we don't know about Maria. And there's a lot we don't know. First, let's break it down. Maria. We don't know which of her symptoms is concerning her the most, and what her goal is for coming to the doctor today. We don't know much about the character and quality of her headaches, and how they are affecting her life. The pain. We don't know much about the diffuse pain. There is ambiguity as to where it is located, and possibly it could be due to her swimming. So I'm curious if she's always used swimming as an exercise. We don't know about her career tenure experience, and I'd like to spend some time finding out more about how her tenure experience is affecting her and how it's affecting her social life. And we don't know about her blood pressure. We don't know if it is usually elevated or if this is more of a one-time thing. And I'd like to know more about any medications she is taking. With all the information we do not know about Maria, and considering the information deficits, I came up with 5 differential diagnoses for Maria. Based on the information I had, I suspected Maria could be suffering from any of the following 5: systemic lupus erythematosus, Takayasu's arteritis, major depressive disorder, chronic tension headaches, or fibromyalgia. Systemic lupus erythematosus is a chronic autoimmune disease that fits Maria's situation because of her age, her sleeping problems, the tenderness around some of her joints, her family history of autoimmune, and the lupus headaches, as they are called. Takayasu's is on the list, on the other hand, because it is a rare type of vasculitis that causes inflammation and damage to the aorta, and it fits because of her age, the elevated blood pressure, the pain in her limbs, and her headaches. I'm going to skip major depressive disorder and come back to that one. I thought Maria could have chronic tension headaches because her chief complaint was concerning these headaches that she's been having that are persistent and have episodes of worsening. But this condition did not explain some of Maria's other symptoms nor incorporate her family history. Finally, fibromyalgia is on the list, as it is one of the most common musculoskeletal conditions, and it is a potential diagnosis for Maria because of the diffuse tenderness and pain around Maria's joints and her chronic headache, both symptoms of fibromyalgia. In light of this list, I came to the conclusion that major depressive disorder fit Maria's presentation to the best, and for the remainder of the presentation, I will discuss my reasoning, briefly touch on the pathophysiology of major depressive disorder, discuss some ethical concerns, explain various diagnostic criteria, and conclude with treatment options for Maria. The pathophysiology of major depressive disorder, and rather any mental disorder, is complex since in most other aspects of medicine, there is more likely than not cause and effect. But rather, in psychiatry realms of medicine, there is really only association at best. Therefore, there is no clear diagnostic neuroanatomical findings that are consistently found with major depressive disorder. However, several areas have been found to be associated with major depressive disorder. The 4 major areas that have been found to be associated with major depressive disorder and depression in the brain are the prefrontal cortex, the medial thalamus, the anterior cingulate gyrus, as shown in the lower photo, and the frontal lobes. Specifically, hypoperfusion of the prefrontal cortex and anterior cingulate gyrus, increased cerebral blood flow to the medial thalamus, and reduced frontal lobe volumes. In addition to these associated anatomical changes in the brain, genetics also play a role in major depressive disorder, such that researchers in 2007 found that people with a shorter version of the 5-HTT gene presented in the lower photo, a serotonin transporter gene, were more likely to become depressed in response to stress and had a disadvantage if they experienced stressful life events. In reality, there are many possible reasons why major depressive disorder can occur, whether it's structural changes that occur in the brain, genetics, neurotransmission issues, the environment, stress. Nevertheless, many factors are at play. And specifically for Maria, we can look at three areas: the environment, biological, and psychological. And if you look at these, the things highlighted in red could be things that are possibly associated with Maria's major depressive disorder. The stress and possible anxiety associated with tenure, her family history of suicide, which could be related on a genetic level or environmental, as we do not know when these suicides happened and how they are affecting Maria. Also, her age, her gender, maybe the presence of a shorter gene potentially, many other factors that could be considered that could be causing Maria to suffer from major depressive disorder. Because depression reaches far and wide into people's lives, and because of the common associations rather than cause and effect, many believe depression to not be as real of a disease as others, and it plagues it with a terrible stigma. Thus, I wanted to spend a moment discussing the ethical considerations. The ethical considerations and stigma of a major depressive disorder diagnosis. I found this quote that really explains the seriousness of a psychiatric diagnosis. Psychiatry, by its nature, touches on big moral questions. The conditions we treat often threaten the qualities that define human beings. These conditions often are characterized by great suffering and stigma. And with this quote in mind, we can frame our talk about ethics and the 4 principles of ethics, with special attention to 2: beneficence and autonomy. Beneficence, where a physician seeks what is best for the patient, and in this case, whether that is helping Maria find a psychiatrist, maybe at her work or near her work, working with her as a family practice physician, which sometimes has been found to be more beneficial to patients because they don't want to get the idea in their head that they are actually going to a psychiatrist. Whatever it may be for Maria, but taking the time to understand what is truly best for her in this situation. And looking at autonomy, respecting the authority of the patient. And with autonomy in mind, I want to make it clear that I am inviting Maria to explore her depressive symptoms with me, to build trust and a relationship to ultimately facilitate the best care for Maria, whether it is with me or another physician. Therefore, going forward, I find it imperative to invite Maria to engage in this discussion with me and to inform her about the process of diagnosing major depressive disorder and what options for treatment she will have, and together we can create a plan. There are a few test options Maria and I can explore for diagnosing major depressive disorder. The DSM criteria serves as a checklist, and there can be a qualifier now that is added in the DSM-5 for a qualifier of anxiety, which might fit well with Maria's symptoms, something we could explore. There is also the Beck's Depression Inventory, the PHQ-2, and the PHQ-9. Beck's is a 21-question questionnaire where the patient ranks themselves from 0 to 3, whereas the PHQ tests are shorter and only 2 and 9 questions and are used to assess the patient's mental status. All of these could be used in combination. In addition, I would recommend some blood tests to assess for anemia, thyroid, and vitamin D levels, to rule out any other possible issues, and to specifically eliminate lupus and Takayasu's. Some more expensive options I want to present to Maria are some different genetic testings. Maria could get genetically tested for the 5-HTT gene I mentioned earlier. There is also a multi-assay serum test that has recently been found to be able to distinguish between depressed and non-depressed individuals. But again, these are very expensive options and may not be reliable, but I want to present them to Maria as an option. Finally, I want to discuss various treatment options with Maria. First, I think it is important to approach this in a comprehensive body, mind, soul approach, so that Maria, if she chooses to take antidepressants, does not have to see it as just taking a pill or medication, but rather feels that her treatment is truly comprehensive, and so we will focus on her entire being. Let's start with the body, the purely physical. We can discuss fitness here, exercise, manual medicine, OMT, massage, and medication. And here, Maria also has some options for testing that will help indicate which antidepressants will work best for her, such as Genomine and other personalized blood analysis tests that she can explore that help select what antidepressant would work best with her genes. But these again are very expensive and run to be about $3,000 each. Now let's discuss mind, the physical and the metaphysical, where cognitive behavioral therapy and interpersonal therapy might really benefit Maria as they try to reconstruct dysfunctional thought processes and help address interpersonal relationships. Having this combined approach of body and mind can really benefit patients with depressive symptoms so they feel they have more control over their condition. And finally, to complete my comprehensive treatment plan, I want to discuss the importance of using OMT for patients with major depressive disorder and recommend this to Maria. If we recall, one of the osteopathic tenets is that the body is a unit of mind, body, and spirit, and thus I would like Maria to explore manipulative therapies that could help her symptoms. A study in 2001 showed that OMT helped 100% of patients improve their Zung depression test score, and overall, various other studies have looked at the effects of OMT in psychiatry and have shown great benefits such as reducing psychotic inpatient days, producing a cannabidiol effect, and reducing anxiety. There are various OMT approaches and techniques we could use to treat depression, some of which would include a whole body assessment, focusing on the sympathetic nervous system around T1 to T6, and looking at the lymphatic system and maybe doing a thoracic outlet technique. There's also various different head hold positions that could target neuroanatomy deviations that I mentioned earlier. Overall, a holistic approach for psychiatry can really benefit patients because it targets all aspects of someone's being and is comprehensive in that it includes medications, OMT, massage, exercise, and CBT therapy that could really help Maria manage her symptoms and help her feeling better. Overall, this rounds out my evaluation of Maria and my discussion of major depressive disorder from an osteopathic perspective. Thank you.